Greetings from Rajiv Gandhi Cancer Institute and Research Center. And incidentally, this year we are celebrating Silver Jubilee since inception. At the outset, I would like to thank organizers for inviting me to share our data on oligometastatic breast cancer patients. Other than presenting data at this forum, it has helped us a lot to understand our approach and to adapt to the challenges and nuances of treating these prognostically distant group of patients. We usually see on an average 350 newly diagnosed breast cancer patients annually. If a patient have three or less metastatic site extracranially or up to 10 mets intracranially with a combined volume of less than or equal to 15 cc along with controlled primary site, then it is classified as oligometastatic disease. If diagnosed within 3 months of primary diagnosis, we define it as a synchronous oligometastatic disease, while metachronous oligometastatic disease is defined as disease-free interval of at least 3 months after completing primary treatment. We did a retrospective review of all the patients who underwent radiation for metastatic disease, and thus this is not a true burden of or a true picture of oligometastatic disease. We identified 51 patients with 75 lesions. Intracranial disease was counted as one lesion. Most of these patients did underwent PET-CT while preferred imaging modality as per the metastatic site was contrast enhanced MRI for brain and spine, while triple phase CT for liver and high resolution CT scans for thorax for lung lesions. We usually do biopsy in majority of patients wherever feasible. Approx 80% of patients did underwent biopsy in this review. Over the years, we have gained confidence in treating oligometastatic disease for carcinoma breast, and same is evident in this figure. More and more eligible oligometastatic disease patients are being treated with a radical approach. So how do we treat these patients? Vertebral metastasis, if it is not beyond Belinsky grade 1C, then SBRT is preferred. Otherwise, surgical decompression and stabilization followed by adjuvant SBRT is contemplated. While for non-vertebral bony mets, initially we started with hypofractionated radiotherapy, and eventually for majority of sites now we attempt SBRT. Lung mets are usually dealt by our thoracic surgeon, and if medically inoperable, then SBRTs and sometimes RFA. For liver lesions, there is always a choice between RFA versus surgery versus SBRT, and final modality is decided in a multidisciplinary tumor board. For brain, if solitary lesion, surgery followed by SRS is preferred, while up to 10 lesions and combined volume of less than or equal to 15 cc are treated with SRS. And for all other lesions or conditions, hippocampal avoidance, whole brain radiotherapy plus minus simultaneous integrated boost wherever feasible is preferred. For nodal disease, if feasible, SBRT, otherwise hypofractionated radiotherapy is being done. Let's have a quick look at the results of our review. Locoregional radiation was delivered in 50 out of 51 patients, and NSCT was performed for all de novo patients. Locoregional treatment was MRM in 66.7% of patients, while it was BCS in 29.4% of patients. One patient underwent no locoregional treatment. When radiation was used as post-adjuvant treatment, in BCS, 25% of the patients received conventionally fractionated radiotherapy, while 75% received hypofractionated radiotherapy. Among MRM patients, 64% received hypofractionated radiotherapy, while 36% of the patients had conventionally fractionated radiation. Regional nodal irradiation was done whenever indicated. We could not collect data on details of nodal areas treated. So if we look at the waterfall plot, green bars are the time from the diagnosis to the development of oligometastatic disease, while blue bars are time from oligomets to last follow-up. So if blue bar is starting from the origin, then the patient is de novo metastatic patient, while all others are metachronous patients. Recently, incidence of synchronous oligometastatic disease has increased and probably because of more sensitive imaging modality available nowadays rather than any other reason. Median age for all patients was 47 years and was almost in same range for synchronous and metachronous disease. More than 90% of patients had good performance score in overall population as well as in synchronous group, while metachronous group had the largest share of ECOG PS2 patients, which was 17%. In majority of cases, patients had operable breast cancer at presentation. Also, majority of these patients were hormone receptor positive patients, and HER2 positivity rate was 25% in overall population, while it was 19% in synchronous and 30% in metachronous population. Incidence of triple negative breast cancer was 25% in overall group, and among synchronous group it was 9.5%, while in metachronous group it was 36.7%. This hormone status was as assessed during initial assessment. Change in hormonal and HER2 status in metastatic site biopsy could not be retrieved at this time. Bone and brain were among the most common site, followed by spine, when considering the only metastatic site at the time of first diagnosis of oligometastatic disease. Most common subset in spine was dorsolumbar region. Minority of patients had liver, lung, and intramammary chain involvement, while mixed presentation with involvement of more than one organ was present in 12.4% among whole population, and it was 23.8% in patients with synchronous oligometastatic disease and 33.4% in metachronous population. In patients with synchronous oligometastatic disease, all patients underwent neoadjuvant chemotherapy, while patients with metachronous disease, 33.4% underwent neoadjuvant chemotherapy. Majority of patients underwent MRM as a surgical procedure for the treatment of primary disease, while one patient didn't underwent any loco-regional treatment and other patient had a RFA session for the primary disease. Details of radiation treatment has already been discussed in my previous slides. As expected, majority of patients underwent radiation because this dataset was retrieved from the radiation oncology department, and there were two incidences of thoracic surgery, only two incidents for lung mets, while one patient received conventional radiation to scapular metastatic site, which was treated along with the treatment of primary site as an adjuvant therapy. Local control for oligometastatic site was 97.4% at 1 year and 77.3% at 2 years. For overall survival, event was death from any cause, and time was calculated from the date of treatment of first oligometastatic site till date of event or last follow-up. Considering whole population, overall survival at 1 and 2 year was 79.9% and 56.8% respectively, while median survival was not reached. Among patients with synchronous disease, 1 and 2 year overall survival was 84.7% and 56.4% respectively, while for metachronous disease it was 76.8% and 54.4% respectively. Median survival was not reached for either of these groups. Also, there was no statistically significant difference between these groups in terms of overall survival. TNBC patient had the worst prognosis as expected, and their 2-year survival was 16.8% with a median of 20 months compared to 2-year overall survival of 72.7% for non-TNBC patients with a median survival which was not reached. So being a retrospective study, it was difficult to collect the toxicity data. Out of 51 patients, 2 developed radiation necrosis, while 1 patient developed implant issues post SBRT to IMC node. Finally, to have a better insight and to further refine our institutional policy, we are conducting a network meta-analysis as well as meta-analysis of observational studies for these particular subgroup of patients, so that we can define some sort of we can define our ongoing protocols for oligometastatic disease and develop an institutional policy to how to deal with these kind of situations. Thanks for your kind attention. Thank you.